Okay, welcome everyone. We're going to get started at our Heart Health Lecture Series presented by the Center for the Prevention of Cardiovascular Disease. Next slide, please. I'm Jonathan Newman, the Clinical Research Director for the Center for the Prevention of Cardiovascular Disease, standing in for Dr. Goodman, who had a family emergency and can't be here today, but I will be moderating in his stead. Next slide, please. Um, Over the last 9 years, since 2015, we've had over 60 lectures on a whole host of topics, everything from vascular disease and prediabetes to thyroid disorders, hormone therapy, and more, and their relationship to cardiovascular disease risk. Next slide, please. You can either take a screen grab of this QR code to go to our YouTube playlist, or I'll provide you with the link when you could access the YouTube channel directly to see all of the prior lectures, including the one today from Dr. Williams, and to check for new content. So please bookmark that and be sure to follow along with us. Next slide, please. Coming up next month, in recognition of AHA month, Dr. Underberg, a endocrinologist, internist, and really lipid guru, past president of the National Lipid Association, will be speaking on the topic of lipoprotein A and other dimensions of lipid biology and cardiovascular risk, which will surely be a great talk. So be sure to tune in a few weeks for Dr. Underberg's lecture. Next slide, please. And we have an update as well from Dr. Berger, the director of our center, an update on aspirin and blood thinners scheduled for Tuesday, March 12th from 5 to 6 p.m. Also sure to be a very interesting talk, a lot of new advances and changes in our thinking of using blood thinners, both for primary and secondary prevention. Lots of good areas to discuss there. Next slide. Here's the link that I mentioned to learn more and register about the ongoing lectures from our prevention series. Next slide. And we'd love to have you keep in touch. This is our website, our general email box, hearthealth@NYU Langone. We are active on social media on Instagram and on X/Twitter at NYU CBD Prevent to follow along for some of the content and updates on course schedule, upcoming talks, and various other opportunities. Next slide, please. Throughout the talk, there is a Q&A. I will be monitoring the Q&A and will organize some questions at the end for Dr. Williams. Feel free to post some questions, and there may be some that we can't get to or we'll get to in a different setting, but feel free to post those questions and I'll keep an eye on them as they come up. Next slide, please. Okay, so I'm going to turn this over to Dr. Williams. I will stop sharing. Let me give my introduction about Dr. Williams while we sort of switch over to his slide set. Dr. Williams holds the position of the Associate Professor in Chief in the Division of Adult Cardiac Surgery within Cardiothoracic Surgery here at NYU. He's the Director of the Heart Valve Program and of NYU Heart, co-director. He embarked on his career at Columbia and has been a really integral asset and team member since joining NYU in 2014. And really at the apex of this role, really exemplifies the integrated partnership at NYU between cardiology, interventional cardiology, cardiothoracic surgery, and research. And he's really been a steward of the integrated valve program here at NYU towards determining really the best approach for patient treatment. And he and NYU are really at the forefront and leading in the area with advanced techniques in transcatheter aortic valve replacements, transcatheter edge-to-edge repair for different valve disorders, which you'll hear about, involving the mitral valve and other really cutting-edge clinical research trials for transcatheter therapies. Dr. Williams really has performed more transcatheter valve procedures than any other surgeon in the country. We're the busiest mitral clip program in the Northeast. And in addition, Dr. Williams does a tremendous number of open surgeries as well, really demonstrating the full breadth of skill and expertise in this area. So we're really thrilled to have Dr. Williams here with us today to talk with us about structural disorders of the heart. So, Matt, thanks for being here. Take it away.
Great. Thanks, Jonathan. Are you seeing the correct screen now? Just my slides? Good. Okay. All right. So I'm here to talk about structural disorders of the heart, and understand that structural is kind of a very large encompassing, and for it can range from holes in your heart to what tends to be more common, where I'm going to focus on, is really the valves of the heart. So just a quick overview of how the, in terms of the valves, there's four valves, okay, and there's two on the right side, the tricuspid valve and the pulmonary valve, which you don't see in this picture, and then on the left side, the aortic valve and the mitral valve. Now, as it turns out, in adults, the most common valves that have issues, by a lot, is the aortic and the mitral valves. And, there's two ways that valves can fail. One is basically they don't open well, and we call that stenosis. And the other is that they leak, and that's called regurgitation or insufficiency. And as it turns out, more often than not, when the aortic valve has a problem, it doesn't open well. So it becomes calcified, and I'll show you pictures of that. And we call that aortic stenosis. And in the mitral valve, when that has issues, it tends to be a leaky valve. Okay, it can become narrow, but that's almost exclusively in patients who have what we call rheumatic heart disease, which we certainly see in this country, but it's frequently seen in more third world countries. Now, the tricuspid valve, I'll address very quickly. We do see a fair amount of leakage of that, but it's usually not until it's extreme that we intervene on that. And oftentimes it can be related to dysfunction of your other valves, such as your mitral valve. And the mitral valve not working can kind of overload the right side of the heart, so the tricuspid valve leaks. Now, the pulmonary valve, most of the time there's disease of that. It's related to congenital heart disease. So it's not frequently, in fact, it's very, very infrequently an issue in the adult. But, and again, just a quick overview, the concept of a valve is for it to open wide to let blood out of one chamber to another, and then close to prevent blood from going backwards. So it's kind of a door. You want it to open, you want to make it very easy for blood to get out of it, but then you want it to close, and so nothing can get inside. Okay, so let's again, most of this I'm going to talk about aortic stenosis and mitral regurgitation, which are the predominant problems by far in adults. So now most people have what's called, there's a couple of etiologies for this, but the aortic valve is also a tricuspid valve, and so there's three cusps, as you can see here. And what happens over time, just like sometimes people get calcium buildup in the arteries that causes coronary artery disease, they can also get that on their valve. And when that happens, the valve becomes stiff, it becomes calcified, it becomes stiff, and it doesn't open well. And so imagine if you have a garden hose, and you turn on the garden hose and it flows freely, but if you put your thumb over it, it flows with high pressure. And so the problem is that your heart is now working to get all this blood through a very small hole as a big opening. And that, like any, your heart's a muscle, and so like any muscle, it's almost like your arms and you're lifting a heavier weight now. So it can cause your heart muscle to tire out. And that's mostly relevant when you exert yourself. So when you exercise, go for walks, go upstairs, things like that, the natural response is your body sends more blood to your muscles and such that need it to provide more activity. But if the valve's narrow, it's harder for the heart to do it, and so people get out of breath. Now, it is relevant to discuss what we call a bicuspid aortic valve. Now, like I said, the normal valve is tricuspid, but some people are born with a bicuspid valve, and it's one of the most common, what we call congenital heart anomalies. And this is something that a lot of people born with, they don't necessarily pick it up, when you're younger. And in its own right, they actually don't cause a problem. So bicuspid valves can actually work very well, but due to various factors, they tend to fail earlier in lifetime. Okay, they don't all fail, but when we see a patient who's in their 50s, 60s, now some of these patients understand are in their 20s that have developed failure of the aortic valve, it's more frequently due to a bicuspid valve. Whereas when we see patients 70s and beyond, sometimes it's due to a bicuspid valve, but more often than not, it's just a calcific tricuspid valve. So this is an area that if you have a bicuspid valve, again, it doesn't necessarily mean that you're going to have a problem, but it's something we got to keep a closer eye on because you're more likely to have an issue younger. And there are also some associated conditions with that, with the big one being an aneurysm of your aorta, which is the main tube where the blood comes out of your heart, and an aneurysm is where it enlarges. So that's aortic stenosis. Now, the symptoms I kind of alluded to, but again, some of it is, the more common cause is just aging, and some people get, you get an inflammatory reaction and it deposits calcium there, and that's what causes the valve to become stiff and not open well. Sometimes other issues can be radiation, it's less common. Rheumatic heart disease, as I mentioned, for the mitral valve can also be a cause. Rarely infections, that can be more of an issue with people who develop a leaking valve called aortic insufficiency, which again, we see a reasonable amount of adults, but it's much less common. It's probably 10 to 1 on the stenosis side. Now, the most common causes of aortic stenosis is the biggest is what we call heart failure. And that's not necessarily that your heart fails, but it basically means that your heart's kind of unable to keep up with what it needs to do, particularly when you exert yourself. So that's how patients will present shorter breath. So you'll notice that, hey, you were able to walk 20 blocks daily, it's fine. And then you start noticing maybe after 10 blocks, you get a little out of breath. Or the very frequent ways that people start noticing when they go upstairs, it becomes an issue. The other is chest pain, just because because it does require your heart to work a little harder, and your heart then requires more blood, that some people can get chest pain, and that can even occur in patients who have normal coronary arteries. So it may, sometimes you can certainly have both, and it may present itself more so if you also have aortic stenosis, but again, you can even get that in the absence of blockages of the heart due to the narrowing of the valve. One of the other common issues is we can see people who get dizzy and even can have what's called syncope, or you lose consciousness. So because, again, you're asked your heart to pump more blood, if it's not able to pump enough blood to your brain, then sometimes people will lose consciousness from this. So this is kind of what these are all diseased valves, and you see this is a calcified valve, a tricuspid. On the left, on the right is also a diseased valve, and that's a bicuspid valves. But the way that oftentimes patients will present with this. Sometimes patients will have had an ultrasound and echocardiogram of the heart for other reasons, and we may see this. It's, understand this is also a progression. So people start with mild stenosis and progress to moderate, and then can progress to severe or even critical. And it's, it's impossible to predict the time course, but it's not something that suddenly happens overnight, though it may be that some patients the symptoms. Your heart, you kind of are able to deal with it, and then you sometimes you reach a point which it's just your heart isn't able to keep up in a sense, and that's when patients present with symptoms. So the most common way to diagnose this is with an echocardiogram. And but there are other tests that we might do to help evaluate it, including a CT scan, an angiogram, various issues. Then what we're looking for is we're looking for the presence of severe narrowing and symptoms. Okay, so if we see it's severe, and that's pretty easy to define on an ultrasound, there's not a lot, it's a one of the more straightforward diagnoses to make on an ultrasound. But if we see it severely narrowed and the patient have symptoms, that's our indication to fix it, because we know when people reach that point, your average 2-year survival, if left untreated, is actually only your 2-year survival is only 50%, which is actually worse than most cancers. So it's something that we are very aggressive about treating. Now, also, some patients, we may not have symptoms, but we may notice that their heart muscle gets weaker, or some patients don't have symptoms, but they've gone beyond severe narrowing to what we would call critical narrowing. And if someone has critical narrowing, even in the absence of symptoms, we know there's about a 50% chance of something bad happening in the next 6 months. And that doesn't necessarily mean dying, but it can mean, you have to go to the hospital, you need a more urgent intervention. So in those patients, we also recommend treatment. And the reason we recommend treatment is because we know, I just told you that the outcome of left untreated is very poor, but the good thing is by treating this, patients do incredibly well. In many cases, we take you back to what you would live, how long you would live otherwise. So, as opposed to cancer, which might spread, we can treat the valve. And obviously, like any procedure, there are some risks, but at that point, we know that the risks of keeping your disease is actually higher than the risks of any kind of procedure. So there are a couple ways to fix this, and the standard way to do this is, at least historically, is with a surgical valve replacement. Okay, and in this case, what we do is this is an open heart surgery, and I know this slide kind of looks a little horrifying, but understand this is an absolutely life-saving procedure. And this has changed so much that even right now, when I have to do one of these surgically, most of my patients go home on day 2 or 3 after the operation. So people, this has progressed quite a bit. But the way this works is we open your heart, your calcified valve that I showed you earlier is removed, and then we sew in a valve. Okay, and there are 2 main classifications of valves. One is a tissue valve, and this here is a tissue valve. And this is basically tissue from an animal that's sewn into a stent, and then this tissue starts working. Now, the other kind of valve is a mechanical valve, and this is made of these generally have 2 leaflets. And it's this kind of carbon composites that act as the valves. Now, there's 2 main differences to be relevant for these valves, and the main thing is that a tissue valve does not last forever. Okay, it's just like your other valve failed. This tissue doesn't last forever. They tend to calcify, kind of like I showed you on your native valve. So the durability can be variable, and I've seen patients get 15 years out of them. I've seen patients get 2 years out of them, but most of the time we would expect that you're going to at least get 15 or so years out of the valve before we would have to replace it again, which can be done. So that's the issue with tissue valves. The mechanical valves, in theory, can last forever, but you need to be on blood thinners, namely Coumadin, and you have to take that for the rest of your life. So there's obviously drawbacks to each. Some of the even newer data with mechanical valves may suggest they don't last as long as we expect. And that's not so much because the valve itself fails, because that almost never happens, but sometimes you build up scar tissue around the valve that can limit the function of those. So I would say at this point, the mainstay is certainly for people to get tissue valves, but there are scenarios where a mechanical valve is appropriate. And a lot of that also comes down to your personal preference. Now the other more exciting treatment is what this TAVR procedure, okay, which stands for transcatheter aortic valve replacement. And basically this goes from, I'll show you a picture here. And it basically we go from the blood vessels in your legs. There's different manufacturers. Here's pictures of all of them, but we basically feed up a catheter from the blood vessels in your legs and put it in the valve here. So the old valve does not get removed. The only way to remove that is with a surgical procedure, but basically it's a valve sewn into some type of a metal stent, and sometimes we expand the stent with a balloon. Sometimes it's a special kind of material that expands on its own, but it basically pushes the old valve out of the way, kind of uses that calcium actually on there for it to anchor, and within this it starts functioning. And this is something that it's newer, but it's 14 plus years old, but it's compared to surgical valves, it's certainly not as new. But it is actually now, when we first started this, we were only using it in high risk patients. Then we moved to intermediate risk, and now we've even used to low risk patients. It's now FDA approved, and the early data suggests it's comparable to surgical valves. There are some in higher risk and most intermediate risk patients, TAVR is actually probably superior to a surgical valve. A lot of that comes from the recovery. It's obviously harder to recover from a surgical procedure than a transcatheter valve procedure, but there are patients, definitely a surgical procedure is preferred. Now it's also, as you can see here, these are also made of tissue, like that surgical valve I showed you. So these also are not expected to last forever. And they're new enough that we're still trying to understand. We don't see any huge signals that it's any worse than surgery valves, nor, in many scenarios is it necessarily better, but we'll learn more. And there are certainly some patients, and the way we evaluate patients here is we, rather than make a summary decision that we treat every patient this way, we look at you individually, look at your anatomy, and again, there are some scenarios where one patient's better treated with surgery, another where it's better treated with the catheter options. So and a lot of it really comes down to what your valve looks like. Now I showed you something with bicuspid valves. And there's less data on using TAVR and bicuspid valves, but there's an increasingly amount, and there are some patients that we do TAVR on, and it just depends what the valve looks like. Now, the important thing when we talk to you about this is as I mentioned, these valves don't last forever. So we have to talk about not just what we're going to do now, but what the lifetime management of this is for you. Now, if you're 92 and we're doing this, you're probably only going to need one valve. If you're in your 60s, 70s, with the expectation these valves aren't going to last forever, we need to plan not only the first procedure, but potentially what the second and third procedure might be. And so we do know that the TAVR procedure is good in many patients who have a failed surgical valve. This is a picture of that. And you can see we have the surgical valve here, and then we've placed a TAVR valve in it. And it's nice because this is a kind of almost a perfect landing zone for these valves. However, you can imagine that if, say, this valve failed, to put another one in, you can imagine if we keep putting valves inside valves, it gets a little more narrow each time. So this is not something we can do a countless number of times. So that goes back to what I raised earlier about the lifetime management. So when we talk about this, and when we're talking about, say, a patient in their 60s, 70s, it may be you're not going to be able to avoid surgery in your lifetime, but we'd like it to only have to be once. They only need surgery once, and we'd like it not to have to occur when you're in your 90s. You don't want to have reoperative open heart surgery when you're 90. So we have to be kind of a strategic how we do that. But it's really changed the field a lot with our ability to do this. And many patients that we used to use a mechanical valve for, we now use tissues, so they don't have to be on blood thinners. Now the way it works, if you have this, you see us in the valve clinic, we kind of meet and go over it, confirm with the ultrasound that the valve is diseased, and then the way we decide if we can do this treatment is with a CT scan that allows us to, make sure that you have appropriate anatomy, which most of the time people do. And also we look at the arteries of the heart, and it's nice because we're able to do this on a single visit. You come see us, you get the CT at the same time, and it can, help make it kind of streamline the process. Now, some patients we need to look at the arteries of the heart with an angiogram, but as it turns out, over 50% of the patients, we get enough information from the CT so we don't have to do an angiogram. And I think that's better if we can, we certainly want to avoid any unnecessary procedures. And then make a decision as to what's best. Now, we do these procedures, including the ones I'll show you shortly, in this in a hybrid room. This is actually our hybrid room here. But basically it's set up that we can do, again, the focus here is that we treat the valve in the best way for you, not in what's best for us. It's but these rooms are set up that we could do a surgical valve, we could do a transcatheter valve. And, in the unlikely event that there are any complications, we're able to deal with all those in the same space. So I'm going to move on to the mitral valve. So the mitral valve is the other valve on the left side. Here's another different picture from what you saw before. There happens to be the pulmonary valve, which you didn't see, which is also a tricuspid type of valve. But the other valves are the AV or atrioventricular valves. There's the tricuspid valve, which I mentioned. You can see that has 3 cusps, and the mitral valve. And again, the mitral valve is the one that is more frequently the problem. This tends again to have more leakage than narrowing. Narrowing is almost exclusively in patients with rheumatic heart disease, except for some patients who have had radiation, and very rarely people get a lot of calcium in the valve at much older ages. But the valve, again, the point of this valve is it opens, fills your heart, the left ventricle, which is the main pumping chamber, and then as that pumps the blood to the body, the mitral valve prevents the blood from going back into your lungs. And that's one of the reasons when these valves don't work that people get out of breath, because the blood's kind of backing up in your lung in a sense, rather than going forward exclusively to the rest of your body. Now, there are 2 main types of etiologies or reasons why this valve fails, and we break them into what we call degenerative mitral regurgitation and functional mitral regurgitation. Now, this is kind of example of the normal valve. In degenerative, so degenerative means there's a problem with the valve structures itself. So I talked about the door analogy. This would be that the door hinge doesn't work and it's loose, or the door stop doesn't work and opens too much. So you can see here's an example of a prolapse valve. The second one where the valve kind of billows out a little, or a flail where actually the valve itself is even torn, and so the blood goes beyond. Now the other is what we call functional mitral regurgitation, which is actually quite common. And this isn't, the valve itself works, but the problem is that the heart muscle itself is not how it behaves. So what happens here is that, let's say if your heart enlarges, as the heart enlarges, it pulls the leaflets of the valve apart. So while these leaflets or doors on the valve are themselves normal, it gets enlarged. So it's like putting too small a door in a door jamb, and so they don't meet in the middle. So it's not a problem with the valve tissue itself, it's a problem with the heart pulls the valve apart, so they can't meet in the middle and close it. Now this valve is the incidence is actually quite common. The incidence of people that need to get treated is not as much, but there is increasing the evidence. Now these patients also present pretty similar to in many ways similar to the aortic patients, with the most common being shortness of breath. We don't tend to see chest pain as often with this, or even losing consciousness, but people definitely are fatigued. And we frequently see patients who get, there's a common arrhythmia called atrial fibrillation, which you can get for lots of reasons, but patients who have a leaky mitral valve are more prone to get that, and that's where your heart is irregular and generally quite fast. And we also oftentimes see as blood kind of backs up into the rest of your body, so you can get swollen feet and ankles. Now the problem with this is as it's kind of this vicious cycle, because as the valve leaks, it kind of makes the chambers larger. And as I discussed, as the chambers get larger, it makes the valve leak. So you get this vicious cycle where the heart's weaker, so the valve leaks. As the valve leaks, it makes the heart weaker and weaker. So it progresses, and patients with bad mitral regurgitation and heart failure have a mortality of up to 57% at 1 year. So it's something we are aggressive about trying to fix. We also know that patients with this are more likely to be admitted to the hospital. And again, the incidence of heart failure and readmission is higher if you have more leakage of this valve. A lot of these patients, because they do have weak hearts, they're not great candidates for surgery. So there is a big population that have these leaky valves that we have no way to fix with traditional surgical procedures. So let's just talk about treatment. So now this is an area, so mitral regurgitation, we will see more frequently in, than aortics in younger patients. So there are a number of 40s, 50-year-olds who have leaky valves, and there's a bunch of techniques on how to fix them. And it's, a lot of them involve either kind of getting rid of the bad part of the valve and closing those gaps, or putting these artificial cords, which are like parachute cords. But there's a lot of surgical procedures, and surgery works very well. And again, as I said, a lot of times this is a younger population, and so they're very low risk for surgery. Surgical repair, and we always try to repair if we can, because it's, like the aortic, if we replace the mitral valve, they don't last forever, and the tissue valves deteriorate quite a bit faster when they're in the mitral position than aortic position. So we know that if we're able to repair the valve, which we're very aggressive about, that it's better for the patient, survival is better. Again, they can have a nice, a durable result. But surgery is, for younger, low risk patients, surgery is the mainstay. We actually have catheter procedures, which I'll show you, but those are at this point reserved for patients that are high risk. And that's because surgery works so well. It can be done through sternotomy, or it can also be done with a robotic procedure. We have the busiest robotic mitral surgeon in the East Coast here, does a lot of these, and this, there's some good techniques to be able to do this. Now the other area is some transcatheter approach, just like I showed you the TAVR, and this is the mitral clip, okay? And this procedure, I'll show you a picture, but basically this goes from the vein in your leg and goes up, and we have to put a little hole in one of the walls that connects your heart. It's not a hole that you bleed through, but allows us to get to the left side of the heart, and we're able to put this mitral clip in, and it basically pins the so basically we come across here, we take the clip as you see coming out here, and we steer it in the HMO. We use ultrasound to see this, because this is not open heart surgery, your heart's still beating, but we're able to visualize this using ultrasound, and to some degree an echo. We can steer it, move it all around the heart to get it where we're supposed to go, and then we open this, okay? And the concept here is that we're going to grasp the two leaflets where it's leaking, and it kind of brings those together, okay? So here's what we go to, where the leakiness is, and we go down, and we pull up, and we grab both leaflets here, okay, as you can see here, and then we can close the clip up, and that can get rid of the leakiness. And here, see, now understand it, obviously we don't totally close the valve, because you couldn't survive like that, and so it's usually for something in the middle, so it still opens on both sides. we can evaluate. If we don't like where it is, we can actually reposition this and get it in a better spot. Frequently, we can add a second, third, and very rarely, sometimes even a fourth clip to optimize this. Now, this works very well, but understand it's probably not quite as good as surgery. So we get rid of most, but not all the leakage. With surgery, we mostly get rid of all the leakage or get it down to what we'd call a trace amount of leakage. And so understand that's relevant. If you're 40 and we still leave you with moderate leakage, over the course of 30 plus more years, that could be problematic, which is why at this point, until we learn more, we push more towards surgery. If you're 85 and we leave you with a moderate amount of leakage, that's probably okay. Understand by doing this, we've shown that it helps people feel better and live longer. And so even if we get this down to a moderate amount of leakage with this procedure, patients do well. There are other technologies that do a similar type thing. This is an example. And then we also have some new therapies where we're able to actually replace the valve with a catheter. Now, there's a bunch of therapies out there, and all of them are experimental at this time. We're involved in many of these trials, but again, that nothing is approved yet in this country for replacing the mitral valve. Almost done here. So I will just quickly talk about tricuspid. This, the mainstay of this is surgery still. More often than not, it is concomitant disease. So most of the tricuspids we fix are in patients who are also fixing their mitral valve. There currently is no approved transcatheter approach for fixing the tricuspid valve, but we do have several experimental devices, including this that I showed you, that MitraClip, which we call transcatheter edge-to-edge repair, or TEER, but we've also done that in the tricuspid position. It's not quite as effective as it is in the mitral, but there's some newer technologies, again, things that we're working with here that are all experimental, which can range from a replacement, as you see in this picture, or some what we call annuloplasty, where we kind of go around the outside of the valve and shrink that down to make it so it meets a little better in the middle. So I am going to stop there, and I think we're going to do questions. I mean, here's, if we can, we're happy to see anyone with, like I said, the mainstay of this is valve disease, but there are other structural disorders, and if we can help anyone, then it would certainly be our pleasure to do such.
Thank you, Dr. Williams. That was terrific. I think we have a few questions from that were submitted ahead of time that we can go through, and if there are questions that have come up during the talk, please put them in the Q&A section, and I can review them with Dr. Williams. One of the questions that came up, Matt, was this one here about someone has asked about the future prospects of treating, as you called it, aortic insufficiency or regurgitation with percutaneous techniques. Maybe you can comment on that.
Sure, it's a great question. And, as I showed you with these TAVR valves, surgery works very well here, obviously, for a leaky valve, but the TAVR valves, most of them actually kind of rely on the calcium. Because we don't sew these in, they kind of rely on oversizing and kind of, which we call radial force, but also friction from the calcium. So the calcium in the valve actually helps this valve stay in place. And so someone with a leaky valve doesn't have that calcium. So some of these valves are not ideal to be treated that way. There are patients that we can do, but it's something that it's pushing the limits a little bit, and we need to make sure you're really high risk. But there are valves. There's one in trials now that is designed specifically for a leaky valve. And this valve, it's kind of it anchors itself to the leaflets as opposed to the calcified. And so, at this point, they are not approved yet, but I think we anticipate that in the next few years, and there will be some other valves. So it's somewhere that we're not there yet, but we will be there.
Are those are those balloon expanding, or are they self-expanding? The new ones
current
you're
one
describing?
is self-expanding. Yeah, it's a self. It's got these kind of clips that you rotate
Grab
it,
on.
clips onto each of the three leaflets, and there's still some expansion at the annulus, but yeah.
How about one of the next questions that came up? So, question sort of more at the diagnosis and I guess staging. You mentioned the the heart team approach and kind of your leadership in the valve center of imaging patients and really understanding the best options. Um, what are your thoughts on MRI for diagnosing valvular disease?
Sure. It's, it's an area that I think there is a lot of good research that suggests that they can be very effective, and it's better quantifying the total amount of blood flow going here so you can calculate how much is going backwards. I think in practicality, the research doesn't necessarily correlate with what we're able to do day to day. But I'd say in general, I don't think it's particularly useful in aortic stenosis, your run-of-the-mill mitral regurgitation, but it can be, I think, certainly in tricuspid disease, some mitral regurgitation patients. I think it can be a good adjunct. If there's some patients that, not everyone follows the medical textbooks, and I think it can be helpful in diagnosing in patients where have some uncertainty, or sometimes there are diseases that can be the cause of the valve disease, and the MRI can be useful. So I don't think it's the mainstay. I'm not sure it will be, but I think it can be useful in some cases. It is not, unfortunately, as it stands now, particularly effective at helping guide the therapy. It's more of a tool for saying, hey, does this patient need to have something done at this point?
Got it.
And some
Okay.
people will have a stronger opinion about MRI than I do. So understand there is
Right.
some controversy here.
So the question here about transcatheter valves and their replacement, you brought up, and I thought you gave a very nice discussion of the longevity of the different valve replacement modalities. Maybe you can comment here about what we know about durability of the transcatheter valves and what your thoughts are, let's say, of some of the valve-in-valve procedures, right, for
Sure.
either transcatheter or after a surgical valve replacement.
Sure. So, we still don't know how long the TAVRs are going to last. And we don't have any early signals that they're worse, but we certainly can't say they're better. Interestingly, we do know that they open a little better than the surgical valves, mostly because the surgical valves, they require material, the sewing cuff to sew it to, and these don't have that. So the opening is better. So and that's more relevant for somebody who has a small valve to begin with. If you have a big valve, it's probably less relevant. But all the TAVRs at this point are tissue valves. And so, the expectation is that these are going to fail over time. Depending on what size valve you have they can be replaced with another TAVR, or if necessary, it can be done with a surgical procedure. And like I said, if we're talking about this, say someone in their 60s who maybe needs 3 valves, the way I tend to do it, and this is obviously an extensive conversation with the patient and about their desires and understanding, but we might do TAVR first, then they get surgery, then they get TAVR again. So we're not looking at 2 open heart operations, but there are patients who get a large enough surgical valve that they could have 2 TAVRs in it. And likewise, they may get a big enough TAVR valve that they could have a couple more of those. But it's kind of a anatomy specific for a particular patient.
That's great. Thank you for that. Um, Kind of a more general question, asking about how you think about cardiac rehab and physical therapy. We have a really excellent cardiac rehab program here at Rusk. I'm actually in cardiac rehab as we speak. Maybe you can comment on sort of how you integrate cardiac rehab into the heart team approach here.
Sure. I mean, I think it's very a lot of it really comes down to what the state of the patient when they come to us. Now, understand a lot of patients who have bad valve disease, they're very deconditioned because, despite their best efforts, they're just not able to exert themselves. And so they become deconditioned. And then once the valve is fixed, those patients can, they need to get stronger again. So I think those are the patients that if you are weak at baseline after getting the valve fixed, because now you're not restricted by your heart, that doing cardiac rehab, generally I think outpatients generally preferred, can be very effective to those patients. Now, some are not that debilitated, and once you have, the TAV, the good thing about the TAVR obviously is that it doesn't take a lot out of you, and the recovery isn't bad. In fact, most people, other than a sore groin, leave feeling a lot better than they did before. With surgery, it obviously takes a little more out of you. But I will say, even with those patients, since we've gotten so aggressive and now sending patients home in 2 days, that they get less debilitated in the hospital. But I think cardiac rehab can be a useful adjunct once you've recovered from the aches and pains and things like that, the surgery, to help get your body back in shape.
Thanks. And also thinking about, pre-procedural fitness or prehab is a pretty interesting
Yeah.
idea too. Um, we got a specific question. I know it's not your area of expertise, Matt, or focus, but thinking about valve replacement options for patients with hypertrophic cardiomyopathy, sort of a more complex or different set of physiologic issues. Um, and I think the question is just asking about, how choice of repair, or sort of maybe your thoughts, if you can comment broadly on your thinking, let's say, of some of the concomitant valve disease, mitral regurg, mitral insufficiency in the context of HCM.
Sure. And so that's, one of the obviously common issues with HCM is we see this, what we call SAM, which basically the mitral valve, the anterior leaflet kind of gets, because of the smaller chamber, so to speak, it kind of gets caught in the blood flow out of the heart. And, the nice thing is that oftentimes, if you're able to treat the patient appropriately with medical therapy or otherwise, that can spontaneously go away on its own. I mean, there are some, when patients get to the point where they need surgery, there are some interventions that can help limit that. I will say that patients with aortic stenosis and HCM are a very difficult group of patients to treat, because, as it turns out, by treating their aortic stenosis, it can oftentimes make their HCM worse. And those are patients that we develop what's called a suicide ventricle. And that's a very complex group of patients to treat, because on one hand, we need to fix their aortic stenosis, but again, they're, we doing so can oftentimes push the other problem over the edge in the wrong way. And so that's where having a, multidisciplinary team with our HCM experts and trying different, even including our electrophysiologists, because sometimes a pacemaker can be useful in those patients,
Right.
but it's a complex, tough group to treat.
Yeah. Let's see if there's any other questions that were posted ahead. Oh, so you touched upon this a little bit, Matt, of kind of the evolving state of practice for tricuspid valve disease and right-sided disease. Maybe asking for another kind of comment on that here, or reviewing that again briefly.
Sure. So, most of the time that we see tricuspid valve disease, it is in the context of another problem. And the mitral regurgitation is a very common one. I mean, if you look at even patients we treat surgically, if you look at the number of patients that have a tricuspid valve surgical procedure, the overwhelming majority have that at the time they're also having a mitral valve procedure. So, and with that in mind, there also is some benefit to helping the tricuspid by fixing the mitral on its own, but that being said, if you're operating on someone's chest and they have some, on their heart and they have tricuspid leakage, you want to fix it while you're there rather than need to come back in the future. So, one of the potential advantages of the transcatheter approach is that we could fix the mitral valve. And let's say we're a little uncertain about how bad the tricuspid valve is, we can see how they do over time and then intervene in the tricuspid at that time. But the current therapy is, again, the only really approved way to fix the tricuspid is a surgical procedure. But there was some work on this edge to edge that has been presented and is I think going to the FDA soon, and may potentially get approved. the data is still early, and so we haven't seen anything super compelling that it's effective, but there were patients who did have that procedure did report an improved quality of life, which is important. But again, this is still early data, so we need to see with time. The area where we've been able to very effectively treat tricuspid valve through a transcatheter approach has been replacements, and there's a couple options available that have shown very significant success, and we can get rid of almost all the leakage. And it's actually a more straightforward procedure than people would initially anticipate. So this is something that not approved yet, but it is on the horizon.
That's great. I think that's about it for the questions. Again, I want to thank Dr. Williams for being here with us today. We'll show the slide for the Heart Valve Center with the web address and the phone number for appointments if valve disease and structural disease more broadly is an issue that you or your family or family loved ones may be dealing with. Additionally, we here at NYU and the lecture series led by Dr. Goodman and Anya Coates, who's here with us today, have the Center for the Prevention of Cardiovascular Disease, both here in Manhattan and in Long Island. So here is our number for appointments for really both general and specialized preventive care, including clinical trials and other interesting dimensions at sort of the rapid interface of prevention and cardiac disease. Next slide, please. Again, here's our general email for the Heart Health web lecture series. Anya, can you show the link again for the recordings of prior talks, just so multiple audience members have asked about following along with us and accessing this and prior talks. So you can learn more and register here and get access to all the prior lectures, including today's, for reviewing again. And we look forward to everyone's presence on our upcoming talks. Again, as a reminder, Dr. Underberg is speaking on lipoprotein A and cholesterol in early February, followed by Dr. Berger on updates for antiplatelets and aspirin about a month later in March. So thanks everyone for attending. Dr. Williams, thanks very much for the sort of tour de force and highlights of the program that you've really led here at NYU.
Thank you for the opportunity. Appreciate it.